Good afternoon, everyone, and welcome to our Global and Community Health Seminar Series today. I'd like to introduce Laura Lynn, who is a fourth-year predoctoral student at HSTM and a member of our Global and Community Health track. She is also a Global and Community Health Fellow with a real passion for community health. Laura.
All right. Good afternoon, everyone. My name is Laura Lynn, and I am a fourth-year predoctoral student at HSTM. As the former student leader of HSTM Wampanoag Average Group, I'm excited and honored to introduce our speaker today, Dr. Joseph Patrick Goen. Dr. Goen graduated from Harvard College in 1992 and earned a master's and PhD in clinical and community psychology at the University of Illinois at Urbana-Champaign, during which he pursued an internship in clinical psychology at McLean Hospital and Harvard Medical School. He taught at University of Michigan for 16 years, where he was a professor of psychology and director of Native American Studies. At Harvard, since 2018, Dr. Goen is a professor of anthropology in the Faculty of Arts and Sciences and professor of global health and social medicine in the Faculty of Medicine. He is also the faculty director of the Harvard University Native American Program. As a member of the Ani Grovant tribe, Dr. Goen is a psychologist and an interdisciplinary social scientist who has collaborated with Indigenous communities for over 25 years, rethinking community-based mental health services to improve the well-being of Indigenous groups. A recipient of countless awards and fellowships, Dr. Goen has contributed to 17 books and published over 60 peer-reviewed journal articles. He is currently a fellow in the Interdisciplinary Research Leaders Program of the Robert Woods Johnson Foundation. And with that, I would like to welcome Dr. Joseph Patrick Goen.
Thank you, Laura. Thanks, folks, for having me speak to you today. It's not that I've ever before had opportunity to talk to scholars of dental medicine, so this will be a treat for me, hopefully for you as well. I've been asked to kind of do two things here today. The first was to speak a little bit about the Harvard University Native American Program. I became the faculty director of the Harvard University Native American Program, or HUNAP as we refer to it, a little over a year ago. So I'll do that briefly just to give you some basic broad brushstrokes of what we do there, and then talk to you a little bit about my approach to research based on some early career lessons I had in a research project that occurred prior to the turn of the millennium. And I hope to say all that to you in maybe 35 minutes or so that we can open up for exchange. My understanding is that you can, through the chat function, offer comments and questions. And Laura has very graciously agreed to curate those for us while we have that exchange later. I am, as you heard, an interdisciplinary social scientist. I'm trained in clinical community psychology, which is an interesting hybrid that in some ways questions the tenets and assumptions of clinical psychology in order to be more community engaged. And that really is the backbone of the work that I do, even as I've been a card-carrying member of the American Anthropological Association since I was a graduate student 25 years ago, and speak to anthropologists and other social scientists in interdisciplinary fashion. As you heard, I was an undergraduate here. I transferred in as a junior. This was my third college. I went to 3 different colleges over 5 years. I was enlisted in the Army for a bit in between, prior to getting my bachelor's degree in 1992. And it was during my time here at Harvard that I became involved with Native students, particularly Native graduate students. I was an older student. And at that time, people congregated at Reed House in the Harvard Graduate School of Education, where the Native American program was located. And we formed at that time what was known as the Council of Native American Students at Harvard. And a big goal of that effort during that time was to try to get the university to adopt an umbrella university-wide Native American program. So it took, another decade or so before that happened, but it's kind of a real treat then for me to be back being the faculty director of that program now. I also spent some time at McLean Hospital, one of the affiliates of Harvard Medical School, doing my psychology doctoral internship, where I learned a lot about psychopathology and treatment for folks who are contending with pretty serious mental illness. And that's really important because it forms the foundation for a lot of the things I talk about in Native American mental health, which I'll explore for you in a bit in a minute. It's sort of a point of departure for that kind of work. So the Harvard University Native American Program is celebrating its 50th anniversary this year. It hasn't always been HUNAP. It was first the American Indian Program in 1970 when it was founded using federal dollars to run the program. It really existed for the first half of its time at the Harvard Graduate School of Education, usually on soft money, usually chasing money a lot to maintain an existence, but it's originally designed to try to move more Indian students through master's degree education, some doctorates too, but trying to train Native American educators to go out to communities and do good schoolwork. The existence of the Native American program is pretty important at Harvard because we have here, as you know, the Harvard Charter of 1650, which still governs the university today. And that charter committed Harvard to the education of English and Indian youth. So it's sort of in some of our foundational documents that Native American education is an important part of Harvard's mission. Most Native students and affiliates at Harvard today would point out that Harvard hasn't done the best job of that through most of its history. In fact, the reason that's in the charter is because it became a fundraising opportunity back in the 17th century when Harvard didn't have many prospects because it didn't have any money. And so it was sent folks out to England to raise money to, basically train Indians for the clergy so that missionary work could unfold apace. And, it's interesting and important to point out that Harvard University sits in the traditional territory of the Massachusetts people. And Massachusetts and Wampanoags and lots of other regional peoples have all been impacted and influenced by Harvard over its many centuries in ways that have not been fully traced or appreciated yet. So the program exists today in part as an expression of Harvard's commitment in realizing that charter, I would say. I would drive you to our website, hunap.harvard.edu. We reformed that just last year, and it's got a lot of information that will be useful to back up some of what I'm telling you very briefly here today. Our mission really is fourfold. We think of four different components. There's education, of course, there's community, there's scholarship, and there's inclusion. And so the events and activities and priorities that we undertake at HUNAP are all wedded to those four main domains of activity. In terms of its structure, the Harvard University Native American program is an inter-faculty or a cross-school initiative. This is, again, what we were asking for back when I was an undergraduate student with the Indian Club here, trying to get it into the Office of the Provost and Central Administration, which is ultimately what happened. It has a faculty director, which is me, and 3 staff members, an executive director, Shelley Lowe, a community coordinator, Jason Pacino, and an administrator, Sam Hernandez. And as of 2018, Harvard really did a breakthrough effort to hire some folks with some faculty with expertise in Native American and Indigenous studies. And so in 2018, 4 of us arrived. That would be Phil Deloria, who's in history, my partner, Taya Miles, who's also in history, myself, and our colleague over in Department of History of Art and Architecture, Shawan Kinu. And so really there was a huge jumpstart of the faculty commitment that Harvard expressed for Native American Indigenous issues. And that, of course, has transformed the kinds of things that HUNAP can imagine doing going forward in the future. We reconstituted our faculty advisory board this past year. We have 9 people, 9 faculty members on our advisory board at this point. Most of us are clustered in FAS. There is one colleague in the law school, one in the Kennedy School, one who bridges over to the divinity school. I bridge to the medical school, but it's pretty FAS centered in many respects. And we have a number of students who identify as Native American or Indigenous here at Harvard. We currently have over 200 that have identified that way. A good number of those, of course, are in the college, but really in all the schools, there's usually at least a couple students who identified in this way. And so that's just a bit about HUNAP and what we do and why we're here. And so we can talk more about that if you want to know more about our programming. Now, what I want to do, though, is shift into the other piece of what I was invited to talk about, which is some of my own research and activity. So let me see if I can share my screen and open up a PowerPoint here. Terrific. So some of you might have had opportunity to look at some of the articles I sent. I was asked to send some readings. So for those of you who are in training or whatever, maybe had opportunity to look at those. This will in some ways set the foundation for a lot of that reading you might have done. I'm talking today to you about the post-colonial predicament for American Indian mental health services, early career lessons. And you'll see here that I have the post in post-colonial in parentheses, because it's not entirely clear that we're after colonization yet. In fact, when it comes to settler colonial nations, it's not clear what after colonization really looks like. So that's why it's bracketed in this way, just for your own information. We need to, of course, recognize and understand that there are American Indian mental health inequities or disparities that characterize most identifiable Indigenous communities in the USA. That is, we have epidemic levels of distress in many of our communities, high prevalence of trauma and substance abuse and suicide. And yet community mental health services that are provided to address these issues are really underfunded. So we have a large unmet need. So one might imagine in the context of these disparities in which we have pronounced mental health problems, but underfunded mental health services, that the solution is simply to expand the mental health services, right? We should add more funding, get more providers, get more services online and available in communities to address this issue. Makes sense, but for reasons I'm going to talk about from an early career experience, there might be more to it than just that. So in terms of these early career lessons, as I said, prior to the turn of the millennium, one of my earlier research projects, I went home to the Fort Belknap Indian Reservation in north central Montana to explore in more anthropological fashion the links between American Indian culture, coloniality, and distress. When you're trained as professionals, we, especially if you're in a health science of some kind or a clinician, you learn all the background and foundations for the knowledge you have about how to do the work that you do in a technical, proficient, and competent and ethical way. But in this instance, what I wanted to do was to bracket all of my professional training, all that I had been taught, to try to amplify and prioritize the on-the-ground local understandings of these issues. And so open-ended interviews are what I undertook in discovery-oriented fashion. I worked with an extended family group on the reservation in particular to try to understand better how people on the ground there think of the links between culture, drinking, and depression. Culture, drinking, and depression. And there is a term in medical anthropology described as an explanatory model, which is a way of trying to capture how people make sense of these different forms of suffering and the links, where they come from, what to do about them. And so I was interested in trying to unpack what explanatory models I might find through this inquiry. And idioms of distress is another medical anthropological term, which has to do with the distinctive ways that some people or some communities talk about, express, and label their different kinds of suffering. So again, in sort of quasi-anthropological fashion, I was interested in trying to learn more about culture, drinking, and depression with reference to these kinds of approaches and concepts. In my work there, I really undertook and found valuable a particular interview with a middle-aged monolingual tribal member who was both Assiniboine and Gros Ventre, the two tribes on my reservation, who decided in our work together to go by his Indian name of Traveling Thunder. Traveling Thunder was interesting because he was not someone who had a great deal of exposure, direct experience with mental health services on the reservation. He was in fact a grassroots activist fighting the mines that were polluting some of the environment off our reservation. He was a self-identified traditionalist, which means that he felt like going back to traditional Indigenous ceremonial and sacred practices he were really important for Native people. He rejected Christianity essentially in the way that some Native people do. And in talking with Traveling Thunder about culture, drinking, and depression, and trying to understand how he connected these things, he offered a really coherent, quite fascinating, I thought, discourse of distress about the relationship of these problems and the origins of these problems and what to do about them. And in fact, he charted them out in reference to 4 different historical eras. So what I want to do next is kind of unpack for you the different eras he talked about. The first era he described in such a way that I kind of labeled it as paradise. It was an era of pre-colonial existence for Indian people, in which he described this as follows, quote, "See, there was no alcohol in this continent 500 years ago. There was no drugs. There was no problems, no domestic problems, no social problems. Everything was good because everybody lived according to custom and teachings. And there was no jails, no hospitals, or no prisons, no insane asylums. There was none of that stuff because everybody lived according to a strict custom." And so you see during this era of pre-colonial existence that he described or characterized almost as a kind of paradise, that there was perfect harmony and balance owing to strict observation of custom. But of course, that didn't last. The second era came about historically, in which European colonial contact occurred. Conquest was the result. And here's how he characterized this era. Quote, "But when the white man came, they forced the Indian people to get rid of their way, their religious, spiritual beliefs. They forced them to trade their economy, which was based on the barter system and on living off of the land, the wildlife, fish, and the herbal medicines. Then they turned around and forced their culture on them, their religion, their beliefs, their foreign ways onto them by taking all of the young people out of the homes and putting them away in boarding schools and forcing the white man's teaching on them. It's genocide. So here he made reference to white dominance, subjugation of indigenous cultural and spiritual beliefs, and the long legacy of the American Indian industrial or boarding schools, which were designed to almost coercively assimilate lots of Native kids into mainstream society, albeit at the lower socioeconomic echelons. So really what he's pointing to here, though, is underscoring the annihilation of custom. There was custom that kept things in order. The conquest led to the annihilation of this custom. And a third era resulted, an era that I characterize really as loss in response to how he described, in some ways, the post-colonial effects of this conquest. Here's what he had to say, quote, "If you don't know your own true oral history, your true oral traditions and customs and where you come from, and what's supposed to be important to you, well, you're going to feel empty. You're going to feel like you don't belong because we don't fit in with the white man system. We never did and we never will." It basically boils down to pride. People ain't proud of who they are, where they come from, what they're doing. Then they're going to be doing these things, alcohol, drugs. And once you're into alcohol and drugs, they're going to probably get into a depression. And you're going to not feel worthy of being a human being, and you're going to want to kill yourself. So here he talked about what we might refer to as anomie, which kind of means no law, no norms, normlessness, as a breakdown in all of the things that give orientation, purpose, and meaning to who you are, where you fit, what you're supposed to be doing, as the pathway to pathology. And indeed accentuated or highlighted the, quote, white man system, unquote, as really the pathogen in this particular instance. So the white man system pathogenic, leading to this kind of anomie, which is then traces out into alcohol, drugs, depression, and so on. Fortunately, he didn't think that the third era was where we are stuck at. He talked about a current era of revitalization in which post-colonial remedy could be possible. Here's what he had to say about that, quote, "After we looked around and realized that we left something behind, we started going back to the hills to fast. We started going to the sweat lodges to pray and to sweat. We started going to the elders to learn. We never was happy living like a white man. I would give the credit to the creator and to the spirit world for pitying the people to allow us to get our sacred traditions back. To me, what that ceremony does is you're calling on the creator, the spirit world, for life or for good health or for a good, clean mind, an alcohol and drug-free mind, or you're calling on the spirit world for guidance, or for survival even survival." And so in Traveling Thunder's explanation, really the solution for these kinds of problems that we've talked about was a return to the sacred custom, almost in a cycle, from the sacred custom keeping things in harmony and balance to being disrupted to having these impacts, but returning to the custom would be the remedy in many respects. So just in terms of further unpacking Traveling Thunder's explanatory model, he identified a really clear pathological process. There's a pathological process, and I highlighted it in red for you, and you can see the order is the same. The cultural repression or conquest would lead to anomie in the way I've described it, which would then lead to substance abuse, to depression, to worthlessness, to suicide. He had a clear linear link between these processes that accounted for the questions I had asked around the relationship between problem drinking and depression. Interestingly, he had fairly little elaboration of personal distress. He wasn't really interested in individual experiences, intrapersonal aspects of distress. He offered a relatively non-biological and non-psychological account. He didn't talk about the things that mental health professionals and researchers tend to talk about, for example, like brain chemistry or genetic predispositions. He didn't even talk about, early childhood abuse or complicated family dynamics. In fact, the psychology that he talked about was actually quite minimized, in some ways occasioned perhaps by my having framed the issues as kind of psychological problems. Instead, of course, as you saw, he emphasized history, culture, spirituality as key to explaining and understanding these problems. Moreover, he attributed it all to the pathogenic aspects of this white man system. He identified colonization as the cause of Native distress. He emphasized systemic factors over intrapersonal factors. He wasn't really interested in the individual and what's going on in them, more about the broad social arrangements that disadvantage Native people. Shared community vulnerabilities, not singling people out as this one or that one with their problems. And I think if you're at all familiar with American Indian ways of talking about social suffering today, you might recognize this as very similar to the concept of historical trauma. In fact, historical trauma captures a lot of this. It's very similar in most respects, but there's one outlier here, which I'll point out because it might be worth some discussion. Traveling Thunder didn't talk about trauma. He never used the word. Psychological trauma was not something that he really focused on. And I think that's kind of interesting because, again, he offered a mostly non-psychological account. So there's room to think about what historical trauma has done since then as it's proliferated throughout Indigenous communities. Well, like me, you might wonder, well, what is then the relevance of psychosocial interventions, therapy, counseling, those kinds of things through mental health services, given this particular explanatory model? Well, I put this to Traveling Thunder. At some point I said, look, I see what you're saying here, but I'm wondering if you had a loved one who was going through a really tough time, you were deeply concerned, under what conditions would you take them down to the Indian Health Service behavioral health clinic and sign them up to see a provider there for help? Well, he grew quiet when I asked that question. It was maybe a 10-second silence that felt like a long time as he gathered his thoughts and said the following, quote, I guess it's like a war, but they're not using bullets anymore. They want to wipe us out, and therefore the Indian problem will be gone forever, but they're using a more shrewder way than the old style of bullets. If you look at the big picture, you look at your past, your history, where you come from, and you look at your future where the white man's leading you, I guess you could make a choice. Where do I want to end up? I guess a lot of people want to end up looking good to the white man. Then it'd be a good thing to do. Go to the white psychiatrists in the Indian Health Service and say, well, go ahead and rid me of my history, my past, and brainwash me forever so I can be like a white man. I guess that'd be a choice each individual will have to make. And he added, I don't like it myself. So the answer to my question of under what conditions would you take someone down is actually, I'm not going to do that. So interesting here is the critique of mental health treatment, a recognition that it's a cross-cultural encounter. But, the thing about cross-cultural activity is that, people from different cultural backgrounds and communities can come together and sort of work out and figure out how to translate, how to understand, and how to, maneuver in light of those different experiences. But in this case, that's not exactly all that's at stake because there's issues of power in play and subjugation and colonial history. And so Traveling Thunder was not just talking about the cross-cultural aspects of mental health services, but also that these services might also act as a form of implicit Western cultural proselytization. And I use the term proselytization to invoke missionary work because a lot of the industrial schools were run by Christian missionaries who were trying to Christianize and civilize the savages. And so I think there is a link to be made between some aspects of mental health service delivery and the way in which the side disciplines, that's psychoanalysis, psychology, psychiatry, psychotherapy, tend to promote solutions for problems in Indian country. So to return to the original question then of what to do in light of the fact that there's plenty of problems and not enough services, simply expanding those services may not be the most one thing to do because we have this problem of cultural difference that Traveling Thunder alluded to. That is, the side disciplines and Indian people emerge from historically distinctive cultural enclaves. And even though there's been so much interaction, intersection, engagement, that some of these cultural differences do persist in interesting ways. In Indian communities, you can still find swaths of people for whom their religious and spiritual beliefs harken back to some of that older understanding, that cosmology. It can be different than that undergirding lots of modern life, and that those cosmological principles can structure people's psychology in ways that are interesting. All stuff I'm happy to talk about more if you'd like to hear concrete examples beyond some of the reading I've talked about. In short, the culture of the mental health clinic is not the culture of the American Indian community. It's probably not the culture of any community, but it certainly maps and accords with sensibilities, say in suburban middle-class America, way more than it would in most communities. But it's not just difference, it's the problem of cultural dominance. This history of colonial subjugation, which sensitizes all of this to the power dynamics at play. You know, the slogan of the boarding schools was "Kill the Indian, save the man." It was a civilization strategy that felt like and asserted that Indian cultural beliefs and practices were primitive and savage. And so these power asymmetries that are expressed, have been expressed historically through these kinds of policies and practices, persist in really influential ways today. So all of this sets up what I call the post-colonial predicament. And this has structured my research ever since, really. On the one hand, we in Indian country have fairly urgent community needs. We often lived in impoverished, high-risk settings, not of our own design, obviously, and that we, as a result, have these documented disparities or inequities in mental health status. On the other hand, it's not just that the services are underfunded. The actual services, in some instances, are incongruent with what people would look to or need for therapeutic benefit or help in times of crisis. It's what Traveling Thunder talked about, an invitation almost to brainwash me forever so I can be like a white man. And this has been attested to by community anecdote and research evidence in ways that I can unpack later. All of this sets up, as I've found over the past 2 decades in my career, really an alternative or alternative Indigenous discourse about mental health. In other words, there's, the way psychiatrists and psychologists and mental health professionals think of and talk about mental health, but I see Indian people and advocates and communities really asserting things that can be systematized almost as a form of parapsychiatric understanding that's Indigenous as opposed to sort of modern and professional. So here are 4 domains in which we can see some of these contrasts. One domain is the domain of the problem, in mental health, we have the Diagnostic and Statistical Manual of Mental Disorders. It's the Bible of psychiatry. It has 300 different disorders, all neatly classified with diagnostic criteria. But this is not of interest to the Indian people who I know and work with and have consulted with in Indian country. Really, they see the problem as historical trauma. They see the problem in the way Traveling Thunder has talked about the problem, although with the historical trauma does capture more of a psychological component, I think, than Traveling Thunder did. In terms of what the goal is of trying to restore people to wellness, the aspiration is not neoliberal individualism in which free agents navigate free markets to pursue wealth and happiness in the way we might imagine people's lives being ordered and organized in middle-class America, but rather Indigenous forms of self and personhood. Selves that are maybe more distributed beyond the physical boundaries of our body into the kinship relations we occupy, into the lands and landscapes, some of which are animate that we have relationships to in American Indian communities. These kinds of forms are the aspiration of what we would want to restore to. The treatment or the intervention, therefore, is not the latest, greatest scientifically generated technologies that psychiatric researchers and psychological interventionists develop and design and test, but rather reclaimed healing practices. That is, there's a notion that Indigenous communities had and have therapeutic approaches of our own that may be actually better suited to remedying our problems in post-colonial sense than importing the latest, greatest psychological technologies. And even evaluation is construed in different terms. It's not really an enamored homage to science. I think there's some skepticism about behavioral science, social science in our communities, but rather a promotion of Indigenous ways of knowing, of trying to find and prioritize epistemologies, ontologies, ways of valuing knowledge in ways that look more traditional and more continuous with the native past what you would find here. So we have then this kind of parapsychiatric alternative Indigenous discourse of mental health that I find wherever I go in pieces or fragments. It may not always be systematized exactly like this. In some ways, that's my contribution, is trying to pull it together so we can see it in terms of these relationships. But I think if you spend any time in Indian country, you'll hear snatches of this kind of a discourse at work when it comes to mental health issues. All right, I didn't want to take too much time today to say too much, so I'm pleased to see that we're at the bottom of the hour. I've written a lot about this stuff. This was early, then I've done a lot of unpacking of these things, which we can talk more about. You've read some of it today, but my website is a place where almost all of my publications are available for download. So having said that, let me go ahead and stop sharing my screen and then see if we can get Laura back on the line to help us to process exchange. Thank you.
All right, thank you, Dr. Gahn, for your presentation. And Christina, if you can turn on my video again, that would be great. Yep. Okay, so does anybody have any questions? Feel free to put them in the chat or put them in the questions box. I could actually start because I do have a question. Yeah, first of all, that was a really fascinating presentation. Thank you so much for sharing. And I am curious, you were kind of leading to this question too, when we were talking about Traveling Thunder and him discussing about the different eras. I'm curious as to why you think that he never mentioned the term trauma or historical trauma when talking about all these experiences.
Yeah, sure. I think it's a really interesting question. And I think that what we can take for granted in modern life, if we're not familiar with all other peoples around the world who have different kinds of social organization and social arrangements, is the notion that a kind of psychological mindedness is normative. So, one can trace interesting aspects for why that might be the case in the affluent West. That individualism really depends on a certain degree of affluence. And that affluence in the West, of course, was through centuries of colonization and plunder and exploitation of other peoples all around the world. But it can fuel a kind of individualism that then requires or benefits from a lot of thinking of individual psychological aspects. So, we're kind of invited almost normatively in modern life to be reflective, to know thyself, to have deep interiors, roomy, inside sorts of spaces that are richly furnished, and to know about those things, to delve into those things, to figure out how to give rise to and express who our true distinctiveness is. All these are aspects of individualism. And, this is sort of a recent invention in the world, in world history. It's also the case that I think most peoples around the world are not so psychologically minded. It's not that they can't be, or they aren't in times, et cetera. There are different ways that it gets played out. But I also think that it's in terms of like a resting orientation to your life. I think most people in the world are probably much more sociocentric rather than egocentric, much more interdependent in ways that individualists are not always as comfortable about. And so one of the challenges, if we want to reach the kinds of suffering that mental health professionals are trying to remedy around the world, is to take stock of the fact that maybe finding ways to be helpful that doesn't require psychological mindedness to such a degree could be the way to go. Now, that's a little bit tricky because psychotherapy, psychological services are sort of about that. And so a lot of what happens when people who are maybe not middle class, maybe not women, maybe not American, or coming from affluent societies, what happens then when they encounter something like counseling and psychotherapy is they have to learn all of that stuff. Some come to value it, lots walk away. There's varying degrees of engagement. But I think that's sort of the dilemma when it comes to issues like this. So why didn't Traveling Thunder talk about trauma? First of all, trauma rose as a colloquial way of talking about our experience over the past maybe 40 years, 30 years. So historical trauma didn't even enter the scientific literature in mental health circles until about 1995. So that's only been with it 5 years. Trauma itself has swept. Now it's everywhere. We talk about it. In some ways, it was really catapulted by the inclusion of post-traumatic stress disorder in the DSM in 1980. So there's a whole set of histories there. But I want people today, because the historical trauma is now the term even, really do have the psychology in mind. Keep in mind that historical trauma was primarily promoted by actual clinically trained health people. So it really is a health discourse that sort of presumes the psychological aspects and behavioral aspects that Traveling Thunder didn't appear to.
That makes sense. And I see two questions over here. I think I would like to lead us to Sandoz's question first, just because it's a little bit more related to what we were just talking about. Sandoz asks, oh, well, first of all, she says, hi, this is a great topic. Thank you, Dr. Gahn. Have you experienced a person going back and forth between the modern colonized methods of spirituality and the healing original practices of American Indian communities?
Yeah, so back and forth is kind of I'm not sure if that's the best way to characterize what is very common. So as human beings, we take stock of the variety of practices, snatches of belief, ideas we're exposed to, possibilities that come into our awareness, into our lives in some ways, in a way that's not always completely consistent or coherent or put together. So the thing about culture is that one way that I think in the health sciences, certainly in professional psychology, people think of these as culture as a bounded community of people who are more alike than not alike. And they contrast with other bounded communities of people who are also more alike than not alike. And between them, they're quite different. But I don't think that's really the way anthropologists think about culture. And some anthropologists are so afraid of how culture has come to distort the way we think about groups and interactions that they don't even use the term culture anymore. But I think it's better to think of cultural practices as ideas and repertoires of action that circulate throughout the globe. People learn, they watch TV, they talk to, they meet, they share, exchange practices, etc. So what we have really is a swirl of different activities and engagements that come with sort of scripts and understandings that we sometimes repackage for our own use. And so when people are pursuing health benefit, of course, they go to biomedicine, they go to what they want, something that works. And so the simpler you have access to something that works, that's probably what you're going to do. Why spend a lot of time engaged in something if it's simple to? So if you don't want the flu, you get a flu shot, it's available in your community, go get a flu shot. Now, not everyone believes in vaccinations for reasons we've heard of. But I'm just saying that people definitely, when they're suffering, will often do a hodgepodge of things. And in fact, most people who are getting biomedical healthcare services are also doing other kinds of things for their health. Often they don't tell their doctors what they're doing because they don't feel like the doctors will believe it or support what they're up to, et cetera. So it's not uncommon for people to mix and match from different traditions, particularly in the domain, if you're seeking cancer treatment or other kinds of things where there's not good, where the solutions are uncertain in their outcome for people, lots of things come into play. Now, with regard to mental health, I think people also, for those who can be enticed to, who are maybe not comfortable with psychotherapy, psychological services, to take a stab at that, even if they end up taking it up and finding benefit in it, there is also probably spiritual stuff going on, just like we would imagine in general. So it's not really trying something and going back so much as pulling things together in a way that works for you to accomplish some end. And in some ways, culture is about affordance. It's about making possible actions to some outcome in some patterned, scripted way that makes sense and is intelligible to you. And my point here is not that all Indian people are so different than non-Indian people and none of them would want psychotherapy. We have a great deal of diversity in our communities. There are Indian people who take to psychotherapy like ducks to water, or who are so thoroughly modern in all respects that it doesn't require any translation. But what I want to do is to complicate the assumption that all Indian people are just ready for psychotherapy. So the work that I'm doing in my career is really speaking to often a swath of our communities like Traveling Thunder, for whom this stuff is viewed with suspicion, and perhaps for good reason for some of the reasons he talks about, but not denying that there are others in my own home community for whom psychotherapy is fine and probably is great for them to pursue in times of trouble.
And we have another question from Dr. Shamut asking, can you please talk about any oral habits related to stress that you may have measured in your studies?
What kind of habits?
Oral habits, so probably something related to oral health.
I know nothing about oral health, so I'm sorry. Maybe you all, well, if we were interacting, you could come up with some things and we could have a discussion about that. It's a little hard in a one way for me to, I know nothing about dental medicine, I'm sorry.
Yeah, Dr. Shamut, would you like to elaborate a little bit more? Perhaps we can start a discussion. Oh, let's see. Oh, this question is actually from Reedy. But Reedy, would you like to elaborate? Okay, so Reedy elaborates and she says, I would like to know if smoking or other stress-related signs like bruxism. So bruxism basically means when people clench and grind their teeth.
Yeah, sorry, I don't know the literature on these sorts of things in dental medicine, so I'm really can't speak to that. I can, of course, speak to smoking a little bit because as a substance abuse issue, American Indian people, I think, die from smoking perhaps more than any other ethno-racial group in America. If it's not the most, it's certainly way up there. And for reasons that smoking in general is widely circulating in poorer communities under stress in the way you're talking about. It's also the case, though, that many American Indian communities have sacred and ceremonial relationships to tobacco. So, smoking has been around for a long time, long before Europeans arrived even. And smoking in part among my own people and people on the Northern Plains, lots of peoples on the Northern Plains, is very, very religious in terms of, and I can speculate a little bit why that may be the case. I think, these spiritual sensibilities are about unseen things that are really powerful and change the world in all kinds of ways. And so how do you see evidence of unseen things? Well, movement and impact in things, and giving visibility to unseen movement in ways that smoke does. So smoke not only is often like if you're burning wood, it transforms one substance to another substance, transformation, sort of ceremonially and ritually important, but it also makes visible the movement of things that are unseen, like air, in ways that smoking then can take on those resonances as well. So for example, when you have a ceremony, and historically in my community, you invite other than human beings to come for a smoke, and you all smoke together. I mean, so because of these kinds of attachments, I think there is an extra little challenge about how to address issues of smoking and its deleterious effects. One way I've seen people do that is to reclaim the kinds of tobacco mixture that used to be in traditional pipe smoking, which is actually not chemically altered in the way that cigarette companies have done to, make it so smooth. I mean, traditional tobacco is really harsh. And so there are ways in which you wouldn't necessarily be doing it so often. I mean, it can be quite a little bit aversive even, unless you're used to it and so on. Anyway, those are some thoughts about some aspect of what you're asking about.
All right, and we have another question. Someone asks, historical trauma was mainly perpetuated or maybe coined by health professionals and scientists. So how can we go about decolonizing these spaces early on in our academic institutions?
Do you have a sense for what decolonizing which spaces? As historical trauma has been primarily promoted by American Indian researchers and scientists who are trained health clinicians. And I should say too, there's a distinction between what the scientific researcher types promote about historical trauma and the ways in which communities take it up. So it's been taken up everywhere you go in Indian country and in Canada and in New Zealand and in Australia. Historical trauma is a term that will be really familiar, probably even in use, with reference to lots of things, certainly to health. But when people use the term in community settings, they're not using the kind of research construct that's been elaborated in all kinds of ways by these proponents in the research world. They mean it in some ways as synonymous with post-colonial distress or colonial origins of our health problems and so on. They're not speaking to some aspects that have distinguished historical trauma in the research world from something like PTSD. And what I talk about in terms of this distinguishing historical trauma from PTSD in this, again, research construal of this concept, I refer to the 4 C's of historical trauma. It's colonial in origin, it's collectively experienced, It's cumulative across adversity over history, because so many things happen, from military conquest to confinement on a reservation to impoverishment to starvation, sometimes things like that. And finally, it's cross-generationally transferred. So the key idea of historical trauma is somehow my ancestors' suffering puts me at greater risk or vulnerability for health problems than if my ancestors hadn't suffered in that way. And it's kind of independent or above and beyond whatever things I personally have experienced. So when academic proponents of historical trauma speak to that term, they're really referencing these 4 C's. But again, people in the community are using it, don't necessarily think of it in quite that way. They often do have a historical component to it, and they have an idea that ancestral suffering inaugurated this long line of things that leads to adversity today. But they're not necessarily talking about like epigenetic mechanisms for how that can be transferred, or even spiritual mechanisms in some instances. And I've written some stuff about this if you want to know more.
All right. And does anybody else have any questions? Oh, yes, somebody else has asked a question. Let's see. Okay, so Sonda asks again, in the line of my previous question, do you see the mix and match in healing and spiritual practices is proven effective as a way of life, or is it only a transient practice to overcome hardships?
Well, I'll take a couple of, I'll stab at that in 2 different ways. The first is to say that there is a sense in which the kind of ceremony that Traveling Thunder referred to as, putting up a ceremony and asking the powers above for good things, good, clean mind, long life, those kinds of things, blessings. There is a sense in most Indigenous spiritual traditions that ceremony and the sacred and following through on your relationships to those other than human beings is what it circulates life, if you will. And life is incompatible with death, incompatible with disease and sickness and poverty and so on. And so there's a sense in which ceremony and the sacred, these religious practices, are therapeutic inherently, because they involve the circulation of life that can drive out things that are negative. Now, in terms of, so there's a sense if people like Traveling Thunder practice these things as an important part of how they go about their experience on Earth, then it's part and parcel of their lives. Just like religious people, for whom religion is important, other people, they live their lives in ways that are consonant with and engaged with and reflect those commitments. And all of that is said and understood to be therapeutic at some level. But it's also the case that in particular moments of disruption from sickness or illness or distress, that one leans on those. In particular, we might have a specific ceremony to try and petition for help in combating, problem drinking, for example, or what have you. So there are moments when it erupts, and it's tailored and fashioned for those specific therapeutic purposes for a person. And again, as I say, people would put things together. So you might do that, and someone might go down to the Indian Health Service, to get counseling. So anyway, it's a kind of a hodgepodge of things. People don't always see the contradictions in the way that Traveling Thunder is drawing some stark contrasts. Not everyone sees those contrasts in that way. And some people might come to see them in those ways if it were pointed out to them, but others might disagree. So, it's complicated, of course, in terms of how any of us manage and negotiate our healthcare relative to the wide range of affordances that different practices, beliefs, and experiences allow us.
Thank you, Dr. Gunn. And actually, Dean Barrow asks, do you see a difference in care-seeking behavior for physical health needs versus mental health needs?
Yeah, so a care-seeking behavior, 2 things I'll say about that. The first is, I think it has to be with pragmatic. When it comes to our healthcare, people want to get better. And so anything that they have confidence in will help them get better, they'll pursue. And biomedicine has come up with some fantastic possibilities for remedying lots of problems that afflict us in ordinary life. And as long as people are aware of those and are confident that it works, they go straight to that. And it's not, you don't think about it. You just go to the doctor and get a pill or get surgery or whatever it is. It's really in the domain of more chronic problems where biomedicine is not lent very certain or very sure beneficial outcomes that one starts to spend a lot more time and energy thinking through and picking on and developing what one does. The other thing is I'm talking about, mental health conditions that are prevalent in Indian country. I'm talking about addiction, trauma, suicide. These are where the inequities and disparities are most pronounced. And these are almost a subset of mental health conditions that maybe don't even deserve to be framed as mental health in this context. In fact, we might think of them as post-colonial pathologies. And everywhere you look around the world where the social order is broken down, where people have, or the government has collapsed, their way of life has come to an abrupt end, these are the kind of things you see. So they're kind of a kind of disorder, a kind of distress that accompanies societal breakdown, that you could almost make and see why Traveling Thunder is identifying what I've called anomie, of normlessness that gives rise to these things. But there are other kinds of mental health disorders that I don't think we're talking about with respect to these sorts of approaches. So if you think of what we call schizophrenia, we don't actually know what schizophrenia is. What it is probably not the one thing that we now classify, it's probably a bunch of things, or autism, or Alzheimer's dementia. These are disorders that are probably more like cancer, tuberculosis, where the causal force they exert in our lives is indifferent to the meanings we make of them. If you've got cancer, it's going to work its havoc in your body, whether you acknowledge, believe, and understand it or not. But addiction, trauma, suicide, these are conditions that are in part heavily constituted by the meanings we make of them. They are meaning-made kinds of experiences and disorders. There's no such thing as trauma outside of a perspective, a point of view that thinks of some experiences as being really harrowing and upsetting, as opposed to other experiences that don't evoke that. It requires an intentional perspective. And so I think these disorders in mental health are the kind that I think are probably most suited to a kind of culture as treatment approach. This is what I hear whenever I go in Indian country. People, we don't need the latest evidence-based practice or empirically supported treatment for mental health. Our culture is our treatment. They mean we can go back to our own therapeutic traditions and find solace and benefit and improvement there. And I think that makes sense for disorders of the kind that are post-colonial pathologies that are constituted, at least in important ways, by the meaning we make. I don't know if that's going to be that useful for cancer, So, it's not that there's no use, but it's not, you wouldn't expect it to have the same impact. So that's even within mental health, we're making these distinctions. You step into physical health more generally, and the distinction holds even more so.
Got it. Are there any other questions? All right, while everybody's thinking, I have one more question for you. I just looking into the future, what are some solutions that you think the IHS can implement, or if the IHS should even be involved in this in terms of improving kind of and addressing the issues that are affecting Native Americans?
Yeah, so the Indian Health Service is really underfunded. That's a key thing. So whatever else it does, it deserves full funding. The history of Indian health and why the Indian Health Service is even created in the U.S. Public Health Service is because of the trust responsibility that the United States has to Indian nations and their citizens. And that comes from this history of treaty making when Indian communities ceded lots of land to the United States and in exchange got promises. And also in exchange reserved certain lands for their own perpetual use. That's what a reservation is. It's a reserve of land that Indian people never gave up and said, no, we're keeping this. So reservations are the part we've kept, but the part we gave away was in exchange for promises for help, support, and so on, which is the undergirding in legal and policy terms for the trust responsibility. The trust responsibility says the United States government owes the requirement to take care of Indian nations. And the Indian Health Service in 1955 was developed because of that. And it's underfunded. So it's owed, but it's not funded properly. So that's a problem. The second thing, though, about the Indian Health Service to recognize is that, the Indian Health Service delivers less and less of direct services. The trend is that tribes take over those services, learn to administer them themselves with the federal money. So the IHS is in the business of shrinking away from direct service privilege and letting tribes who can show that they can administer such a complicated system to run their own healthcare. And then tribes can actually innovate and tailor and decide how they want to run these on their own. So I think the future of Indian healthcare is less about Indian Health Service per se, and more about tribes exercising their sovereign autonomy to run their own health services in the way they see fit, with more money.
Yes. And okay, are there any more questions? Sounds good. Jane, if you'd like to take over.
Well, thank you so much, Dr. Gunn. This has been fascinating and enlightening, and I would love to have you come back and speak with us a little bit more so that we could share with you a little bit about some of the outreach work that we've been doing. Laura's part of the Wampanoag Outreach Group. We have a number of students who have been to the Rosebud Reservation and thinking about how to better integrate oral health care with primary care services. But I think having this understanding of the historical trauma will really help us reflect more carefully about how we can be more responsive to what Native American communities need when we think about oral health needs and integrating care. So thank you so much for coming today, for joining us, and for your wonderful perspectives. And thank you also, Laura, for moderating. I look forward to HSDM becoming more involved with HUNAP as we go forward. So many thanks again.
Thank you. It's been a pleasure, and I look forward to talking with you in the future.
Wonderful. Have a good afternoon, everyone. Bye-bye.